in this study, we were interested in seeing whether the fact that our institution had expanded the availability of elective inductions of labor at a specific time point, if we could do some sort of analysis to see whether that expansion actually reduced perinatal health disparities. And this came from a lot of prior work that's been done with a lot of different teams across the US and across the world, examining how induction of labor can be safely offered to as many pregnant patients as possible who would want it, and how that could improve outcomes related to different kinds of perinatal morbidity. So thinking about things as simple as whether a patient has an unplanned cesarean delivery or whether there are more severe complications during the intrapartum period. And so that's what we set out to do. We got a data set of about 21,000 patients who delivered at our institution who fit specific criteria to be exceptionally low risk for the need for an indicated cesarean delivery. And then we saw if in the pre-intervention period and the post-intervention period, there were actually differences both in these kinds of morbidity related outcomes, but also in whether there were differences in the disparity that we saw within our patient population. We looked at, for our primary outcome, whether or not a patient actually was induced. So just a simple binomial variable looking at whether, yes, no of whether there was an induction of labor. And then secondarily looking at different intrapartum outcomes, such as cesarean delivery, which all of these patients were undergoing a trial of labor, so cesarean delivery was not planned for them. And then also two other intrapartum and postpartum outcomes that we know also confirm morbidity, which are chorioamnionitis, which is an infection of the umbilical cord and the surrounding gestational area during the intrapartum period. And then also whether or not the baby was admitted to the NICU after delivery. And so we know from a lot of prior work that there are racial and ethnic disparities in all of these outcomes where pregnant patients of color are more likely to have more severe morbidity, and more likely to have unplanned cesarean delivery. And in this study, we wanted to do something a little differently. Instead of looking at race and ethnicity as a proxy for sociostructural adversity, we actually used the social vulnerability index as its own predictor variable to gauge that disparity. Which is something that I'm very interested in. The SVI is a tool that was developed by the CDC to measure an individual's environmental and social adversity, and it is a composite of a lot of different variables, and it's specific to the individual census tract. So it's a very specific geocoded data point that we were able to code to all of these pregnancies that we included in our study. And looked at whether there were disparities that changed based on an individual's social vulnerability. And what we found was that rates of cesarean delivery and NICU admission did reduce once our institution started offering induction of labor to all patients 39 weeks or greater who wanted it. And we also saw that the SVI disparity for chorioamnionitis had reduced in the post-change period. This was not something that was always part of standard of care and elective induction of labor. This was something that's fairly recently, within the last 10 or so years, a lot of literature has come out to suggest that in patients who are greater than 39 weeks and who meet a lot of low risk criteria, inducing labor at some time between 39 and 41 weeks gestation could actually be beneficial to them. And a lot of institutions in the wake of this evidence being published, this was this is called the ARRIVE trial for anyone who might recognize it in the audience watching this. But in the wake of that, a lot of institutions re-examined their policies on inductions of labor and who could have it. And I think this neutralized a lot of the inherent biases that were in existence in a lot of different institutions where, if there's a choice between offering or not offering something that you're not comfortable with, for individuals who you feel less comfortable providing care for, it might be more difficult for you to then offer that for them. And I think having this kind of institution-wide policy that offers it to anyone who would want it, regardless of their individual characteristics, I think that would understandably reduce the rate of how bias would impact who can be provided with an induction of labor electively. And so to kind of go to your first question and what institutions should take away from this, I think, there's a lot more research that we need to do in this regard. I think that's kind of sometimes a throwaway answer because that's always what everyone says. But it is true that I think, we're just scratching the surface of what these mechanisms are and these sociostructural barriers to vaginal delivery, right? As something as simple as that. Um, and so what I would say that we can take away from this is that something as simple as offering a service to anyone who wants it electively versus it being, either not clear or kind of provider practice group dependent, that has potential to improve care for everyone.